MI with non-obstructive coronary artery represents patients with less than 50% stenosis in coronary angiography. It represents about 5 to 6%, range is 5 to 15% of all MI cases. It is associated with significant risks of mortality, rehospitalization, disability, and angina burden as similar to the obstructive coronary artery disease. But there is less understanding of the Minoka patient, with its clear understanding will lead to unnecessary avoidance of unnecessary investigations, and optimal treatment can be given. So in this study, we observed various intracoronary pathologies by optical coherence tomography, that is OCT, of all Minoka patients, and excluding suspected cardiomyopathy or myocarditis by means of cardiac MRI. Methods: patients of MI, STEMI or NSTEMI with HS-TROPI positive was admitted to the cardiology department of Sir Gangaram Hospital. Patient underwent then coronary angiography, which showed less than 50% stenosis lesion in major epicardial artery. That is then categorized as Minoka, and then OCT was done to study the intracoronary pathology. Cardiac MRI was used to rule out the suspected patient. Period of study is 1 year, 10 months, including the COVID era time. Results: total 13 patients only has been taken, out of which 85% are males and 15% are female, and age group is mean age group is comparatively a younger age group of 49, and EF is mostly a mild to preserved EF of 53%. Only the 46% are dyslipidemic and 23% are chronic smokers. No hypertensive or diabetic patients are there, and 62% are STEMI and 38% are NSTEMI. And the most common artery involved is the LAD. And plaque characteristics: plaque erosion is the most common to be the find out. That is of 85%. Only one case of plaque rupture, that is 8%, and SCAD only one cases. Rest of the findings are also there, like white thrombus, red thrombus, necrotic core, lipid core, macrophages, thin cap fibroarthroma, and calcium. None of the patients had been suspected of cardiomyopathy or myocarditis. Cardiac MRI could not be done, though has been decided to be done, but due to some financial constraints, cardiac MRI could not be done. Only plaque rupture patient was stented. Rest all were given dual antiplatelet therapy, aspirin and ticagrelor, as per erosion 1 and erosion 3 trial. And that also plaque rupture patient which has been stented, it has some amount of dissection is there, and MLA is also very less. These are the pictures of all my patients, the OCT pictures showing red thrombus, calcium, deep-seated calcium, white thrombus, calcific nodule, and necrotic core with thin cap fibroarthroma, that is less than 60 micrometer. And these are cholesterol crystals and macrophages. This is one case scenario. 23-year male presented with chest pain radiating to the shoulder for last 10 hours. There is no risk factor. ECG shows anterior STEMI. Echo shows hereditary hypokinesia with EF of 48%. HS-TROPI was 19,000. He is a known active smoker. And angiography showed LAD thrombus laden, 30 to 50% of stenotic lesion. And OCT shows plaque erosion, red and white thrombus with ML of 3.83 mm square. This is the ECG showing evolved ST changes in anterior leads. And this is the angiography showing here some 30% with thrombus laden, and this is the OCT run taken, which shows which shows the plaque erosion, white thrombus and red thrombus. Limitation is a small sample size. Cardiac MRI could not be done to rule out the myocarditis. Follow-up not done of those left on dual antiplatelets. Conclusion: this is a small preliminary data showed that Minoka mostly occurs in young patients with mild LV dysfunction to normal LV function. The intracoronary pathology responsible are mostly plaque erosion, which are mostly left on dual antiplatelet therapy as per erosion trial, though this study has some limitation. Only one patient had scarred showing intramural hematoma and one plaque rupture was there who was tented for as per erosion 3 trial. Thank you.